you now. I'm excited to have you guys joining me. So this is one of my very favorites to go through with this information. I love STDs. I don't love STDs, but I love talking about them. I love learning about them. And so I'm so excited that you get to be here with me. Also, genitourinary, sometimes that can be a little bit difficult to discuss and can be, a little difficult to understand. So we're going to go through some of those things too. So just a couple housekeeping things along the way. If you have questions for me, please don't hesitate. Go ahead and put those in the Q&A. I'm happy to help how I can. If you are just answering a general question, please go ahead and put that in the chat. Just as we interact with one another, we're also going to be using Slido today. So those are some housekeeping things. Also, we are offering continuing education credits for this webinar. So you are eligible for one contact hour for attending 80% of our course. We are accredited as a provider of nursing continuing professional development by the ANCCCA. So we are so excited for that. We don't have any relevant financial relationships for any position or individual to control our content, and we don't have any commercial interests or provided financial or in-kind support for our educational activity today. So during our time together, I hope that there are three learning objectives that you are able to meet. So analyze the pathophysiology, that clinical presentation and diagnostic criteria of common GU disorders and sexually transmitted infections in diverse adult and adolescent populations. Evaluate current evidence-based guidelines for pharmacologic and non-pharmacologic management of GU conditions and STIs, with the emphasis on individualized care plans, and antimicrobial stewardship, and also apply that advanced clinical decision-making skills to complex case scenarios. So we're going to be talking about a couple different case studies as we go along today. So I am hoping that as we learn, we're going to be able to meet these objectives. So if you have ever joined one of our webinars before, we use Slido. So you can either jump in at slido.com, enter in that code, all caps APRN GUSTD, or you can go ahead and grab your smart device, scan that QR code there on your screen, and that should get you in as well. So we are going to switch over and look at our first question for today. So my first question is, how do you feel about the GU system? Subjects, STDs, things like that. Are you kind of at the bottom, feeling not so hot, or are you at the top? Like, move over, Jennifer. I can teach this for you. What do you think? Okay, so kind of right in the middle. Okay. So a lot of threes. Couple ones. Okay, we're hoping that during our time together, I'm not planning to turn you into a guru when it comes to this area of expertise, but I'm hoping that as we go through, you're going to gain confidence. So as you're answering questions, I'm hoping that you're going to notice you're answering them more quickly with more confidence in the answers that you provide. So before we get going, let's go ahead and talk about some of the things that we're going to be discussing today. So we're going to talk about some of the lab tests, different diagnostics that we might see, that type of thing. We're going to go through those major STDs, and we're going to talk through treatments for those as well. And then we're going to end our time together with a case study. So that's one of my very favorite ways to learn, is using those case study scenarios, real life, kind of like we're in the clinic setting, learning from our patients. All right, so let's start by using some of those lab tests. We're talking about some of those lab tests. So let me scooch this in for you, make this a little more clear. There we go. I think that should be great. Perfect. So typically we are going to look at a few different lab tests when it comes to the GU system. So creatinine, GFR, BUN, these are the most common that we see when it comes to this system. So we're going to take a look at a few of those blood tests. First up, we have creatinine. So what does that encompass? Well, there's a few different tests. Remember, creatinine is a waste product that's produced by muscle, protein metabolism, and it's excreted by the kidneys, and it makes it a really good indicator of what our kidneys function is doing. So because creatinine levels are part of a BMP, it's a really great way to establish that baseline or even to see a trend in our kidney function over time. So there's also something called creatinine clearance. So you see that in the bottom of that creatinine section there. Or we have a 24-hour urine testing. So it's exactly what it sounds like. We're collecting urine for 24 hours. This is a test that's something you won't likely be doing in a primary care setting, but essentially we use it to compare creatinine levels in the blood to creatinine levels in the urine, and that allows us to calculate the GFR, or that glomerular filtration rate. Now, GFR, now this is easy to remember because it's all about checking in on those filtering units of the kidney. So glomerular filtration. So we're looking at those filtration units of the kidney. And that is the glomeruli. It's really important to know that we don't usually calculate GFR these days. We rely a lot on the eGFR, or that estimated glomerular filtration rate. And this takes into account a couple different things: age, sex, blood creatinine levels, to give us an accurate idea of whether or not the kidneys are actually filtering waste as they should based on those parameters. So something to think about with eGFR is it's been also historically based on race. But there are a lot of studies that are coming out that this is an unnecessary parameter. So definitely something to watch in practice. I want you to be aware of it. But as like we said, things are always changing in the medical field. So like blood creatinine levels, this test is also part of a BMP or CMP, and it makes it really easy to just kind of grab a baseline or a trend over time. Okay, so what about that BUN? Some might hear it called BUN, but the BUN is another component of a CMP or a BMP. And what it does is it measures that amount of urea nitrogen in the blood. And this is a waste component of protein metabolism. So we expect to see the elevated BUN with kidney dysfunction, but know that liver disorders, dehydration, even high protein intake can also increase that BUN level. When it comes to the BUN creatinine ratio, BUN to creatinine ratio is going to compare that BUN to the creatinine, just like it sounds, right? And that ratio can give us a lot of information on what is actually causing that impaired kidney function. A higher BUN creatinine ratio is going to suggest something like pre-renal causes. So usually because the kidneys aren't being perfused adequately, like dehydration or like a congestive heart failure type situation, versus a low BUN creatinine ratio means that there's something going on inside the kidneys. So I want you to think, well, actually, what are some things that could be going on inside the kidneys that you think might alter this level? What do you think? What are some things that could be going on inside the kidneys that might alter this level? You can let me know in the chat. What do you think? Okay, so this could be things like, yeah, infection. Corliss, you got it. Yeah, infection, tumors even, but also liver dysfunction too. Those could also be involved there. Oh no, Slido has you blocked. Oh, stink. Okay, but you can certainly just go ahead and enter your comments in the chat. You can do that too. I'm so glad you're joining us, Anna. So we're going to switch gears just a minute, and we're going to talk about a few of the components of a urinalysis. So urinalysis, we know those are pretty common, right? We use those pretty frequently. So in the OBGYN world, we use these every day, almost for every patient, it feels like. So we're going to talk about those epithelial cells first. Now, epithelial cells, I want you to remember these cells are found on the surfaces of our body, like the skin, the bladder lining. So it's normal for a healthy person to have a few of those cells in the urine, but a large number could indicate something like a UTI, sometimes a yeast infection, or even a kidney disease or cancers. Versus leukocytes, well, leukocytes are what? These are our white blood cells. So when these are in the urine, our ears should perk up and we should start thinking infection. We are thinking infection is probably a high likelihood. Now, typically, we're going to see leukocytes in the presence of a UTI, but they can also be present with kidney stones or even bladder tumors. Okay, what about those red blood cells? So those red blood cells, they are not normal urinalysis findings, okay? Sometimes when we see these in the urine, that can tell us that we have a condition like a UTI, but they can be present with more serious things like kidney stones or even urinary tract cancer. So when we see these, we definitely should be thinking something else could be going on. Protein, proteinuria, protein in the urine is an indicator that something's not quite right with those glomeruli. So remember what we talked about with the glomeruli in the kidneys, those kidney filters. Now, when we see proteinuria, that can have transient causes like dehydration, fever, very strenuous exercise, but it should improve on its own. Okay, let's do a quick knowledge check and tell me which two common conditions would you want to check for protein in the urine? What two common conditions that we see would you want to make sure to check for protein in the urine? Let me know. Really common. Okay, someone said rhabdo. Diabetes, you got it, Abigail. Yep, diabetes. Perfect. One more. Think, here's a hint. So think pregnancy. When would we want to check for protein in the urine? When somebody has hypertension. Malin, you got it. Yeah. So if you said hypertension and diabetes, you're right. We know that both hypertension and diabetes can actually cause kidney damage. So it's really important that we're checking for those things in those clients to assess for kidney dysfunction. And there are also several other conditions that can cause kidney damage that would also lead to proteinuria. So things like lupus, heart disease, preeclampsia, like we just talked about. So we're always going to want to explore what that cause of proteinuria is. We want to dig just a little bit deeper to figure out what it is that's going on. Okay, so down to those nitrates and nitrites. Now, this one is very easy to mix up, okay? Nitrates are A-okay, okay? Nitrates, these are normal findings in our urine. I want you to think the A in nitrates is for A-okay. Now, nitrites, okay? They're a result of a chemical reaction that occurs when bacteria in the urine starts to mix with those nitrates. So when you see nitrites present on a UA, what conditions should we consider? If we see nitrites, what do you think we have going on if we're seeing nitrites on a UA? UTI, you got it. Nice work, Abigail. Urinary tract infection is what we need to be looking at. Now, casts. These are tiny tubed shaped structures that are in the kidneys, and they're made of protein, cells, or other substances that offer us a lot of clues about what's going on in the kidneys and the urinary tract. Sometimes I wish there was just a window so we could see what was going on. But these white blood cell casts are going to tell us there's an infection or inflammation like pyelonephritis versus red blood cell casts might mean that there's bleeding somewhere. So, like somewhere in the kidney tubules, something like that. Regardless, these are something that we definitely want to follow up on. Okay. So, those white blood cell casts suggest infection or inflammation. So, white, so the I in white, infection, inflammation. And the red blood cell casts mean that there's bleeding. So red blood cells bleeding somewhere in those kidney tubules. All right. So last but not least for our UA interpretation, we have pH. So pH, a normal is between 5 and 8 in our healthy urine. So what would cause someone's urine to be more acidic or alkaline? Well, acidic urine, remember, that will be on the lower end of the scale. Okay. So if let's get our handy dandy little marker out here for just a second. All right. So if we have our little continuum here, normal is here, our acidic urine is going to be over here. Okay. Acidic urine is over here. It's going to be on that lower end of the scale. And it can be caused by like high protein diets, dehydration, malnutrition, kidney stones, and ketoacidosis. So that's also a reason someone should have a more acidic urine pH. Now, what about the causes of alkaline? Well, if our acidic urine is over here, then our alkaline is more this way. Okay. So, alkaline causes would be things like infections. So, UTIs is a big one. But we see alkaline urine with kidney failure, respiratory alkalosis, and even GI obstructions too. So, I just want you to kind of remember, kind of have an idea of where those things are and what can cause each of them. All right. So, we're going to go through kind of some things that we can see. So we're going to talk about blood in the urine. So hematuria. Now, seeing the blood in the urine can be pretty scary, right? Especially for our patients. But it's really important for us to remember that there is a ton of reasons why it can actually happen. Hematuria can happen when there's something just as minor as a UTI, or more understandably from a kidney stone, right? So that little ball of yuck that's bouncing around in there and causing some damage. Now, a couple of years ago, I had a kidney stone. I didn't realize what it was, but my side felt like it was going to burst. And my husband knows that when I say, hey, I need to go to the ER, we don't just go willy-nilly because one, it's expensive, and two, I don't want to admit defeat. So he knew that when I said, hey, I need to go to the ER, he's like, yes, I have the keys, let's go. So when I got there, lo and behold, I had this kidney stone. They told me, hey, you'll pass in a few days, just go home, wait it out. Well, I finally did. And I ended up keeping that little guy and I named him Judas because he betrayed me. But it was kind of ugly looking. It had kind of spikes out the side. So when I think about kind of like a game of pinball, this little bitty, which didn't feel very little bitty, but this little bitty piece of um, yuck was in there bouncing back and forth, causing all kinds of ruckus. So it is very common to see some blood in the urine. So urine in the or blood in the urine can also be a sign of more serious things like kidney disease or even bladder cancer. And we think about bladder cancer and our patients with hematuria with no other symptoms. So if they show up, they have blood in the urine, they're like, nope, no increased frequency, no increased urgency, no pain, nothing else. That is absolutely something that our ears should perk up and we should be thinking, hey, there might be something more serious going on here. Now, hematuria can also be sneaky and it isn't always visible to the naked eye. Many times have I had women that came into the office, we dip their urine looks clear, but there ends up being blood in it. If the blood is visible in the urine, we call that gross hematuria. So I like to think about it like if you look in the toilet and you see all this blood, you're like, ew, gross, right? But if the urine looks normal, but blood is found in the UA or even under a microscope, we call that microscopic hematuria. So something that we can't see with the naked eye, but is still there. So it doesn't matter how it presents. Remember, hematuria is always something that needs to be explored further. We need to figure out what is causing it and treat that root cause. Now, one that is I know another common thing that we see in the urine is bacteria. Bacteria. So I want you to imagine the entire urinary tract. Okay, the kidneys, the bladder, the urethra. It's a highway designed for one-way traffic. Okay, and the one-way traffic is the urine going out. Now, sometimes what happens is bacteria, they don't like to abide by the rules. They don't like to go by that one-way traffic rule. So recently in Seattle, there are several one ways, and people are going the opposite direction from time to time. Bacteria can be the same way. They don't always want to abide by that one-way traffic rule. And so they might decide to just head upstream from the urethra and into the bladder, and sometimes even the kidneys. This is called bacteria. Okay. We tend to see this more in women. Why do you think we would see this more in women? What's the big difference between men and women when it comes to that urinary tract? Or let's talk about the urethra would be even a better way. Yeah, we have a shorter urethra, right? So the presence of a small amount of bacteria is normal and really even expected. But if we have an overgrowth of bacteria, that can cause some big problems. So there's two types of bacteria. We have asymptomatic and symptomatic. Now, when you hear the term symptomatic, what do we think about? This is not a trying to trick you, but what do we think when we see asymptomatic or symptomatic, sorry? Complicated. Okay. When I see symptomatic, I think they have symptoms, right? So the term symptomatic bacteria, this is just another phrase for a urinary tract infection. And we're going to talk about here in just a minute. Now, asymptomatic bacteria, on the other hand, is the presence of bacteria in the urine without those UTI symptoms like burning, urgency, things like that. Now, if our patient is healthy, they're not complaining of symptoms, we don't even need to worry about treating it. So, who should be treated for asymptomatic bacteria? Anybody? So, in our healthy clients, if we see bacteria, yeah, if they're pregnant, why is that? Why do you think we should treat pregnant women if they have urine with bacteria in it? Any guesses? Okay. Avoid transference. Okay, so we do this out of just an abundance of caution. So we know that a UTI can cause preterm labor, so we want to be really careful with that. But we're really doing this out of abundance of caution for both mom and baby because bacteria actually increases that risk of acute pyelonephritis for mom and intrauterine growth restriction, premature birth, low birth weight for that baby. So we want to make sure that we treat these women. Now, treatment is pretty simple. It's just this course of antibiotics to treat that bacteria. We want one that's safe for both mom and baby. And most commonly, what I prescribed almost all the time, occasionally we'd have some, you know, changes here and there, but most of the time it was macrobid. It was that nitrofurantoin. We can give Keflex or even Bactrim if needed, but I go with that macrobid. We're going to follow up with them in about 2 to 4 weeks. We want to make sure that that infection has cleared, make sure they're feeling better. If for some reason they have symptoms that develop or they're getting worse, we have them come back in sooner for sure. All right, so let's talk about a common diagnosis that we see in primary care, UTIs. Now, they have many different names. We just talked about symptomatic bacteria, but it's also known as what other name? What other name have you heard a UTI called? So UTI, symptomatic bacteria, cystitis. Yes, Corliss, you got it. Cystitis. So we already know that UTIs result from this overgrowth of bacteria in the urinary tract, right? E. coli, the most common pathogen. But Klebsiella pneumoniae and Proteus mirabilis are two other really common ones that we see, two common culprits, and even sometimes Staph aureus. So let's do a little bit of a recap on our risk factors for UTI. So remember, UTIs are more common in men or women? Remind me. UTIs, we see them more in Men or women? What do you think? In women. You got it. So I have a niece and a nephew. I love them very much. My nephew over the summer, or I think it was early fall, had a febrile seizure. And so my oldest actually had febrile seizures when he was little. And so we were the first phone call that they made trying to figure out, what do we do? They're scared to death, rightly so. So it came back that he had a UTI. They said the culture or the dip was maybe showed a couple bacteria. And I was like, that's really odd because that doesn't typically happen in boys. And so when the culture came back, it was actually negative, but it is more common in women. Now, other risk factors that we see, things like dehydration, those that have poor hygiene or improper hygiene. So, if women are wiping from back to front, if they're holding urine in for too long, hello, medical professionals, we are at risk for UTIs every day, all day. All day, sexual activity, diabetes, even. So, what happens is the bacteria is going to multiply in that urinary tract. And our patient comes to see us with those common UTI symptoms. So things like urgency, frequency, burning when they pee. Their urinalysis is positive for bacteria. We see nitrates, we see lukes, we see elevated WBCs, and might even have trace amounts of protein or blood. So we go ahead, we diagnose our patient with a UTI. But how do we know whether the patient has uncomplicated or a complicated UTI? And how do we go about treating them? Well, it's actually pretty easy to differentiate complicated and uncomplicated UTIs. So let's break this down for just a minute. Uncomplicated UTIs are your healthy premenopausal women who are not pregnant, they're not immunocompromised, and they don't have any comorbidities. Okay. So just your average, healthy, non pregnant woman. Now, complicated UTIs consist of pretty much everything else. So this is going to be things like our pregnant women, children, elderly, if they have UTIs that are occurring frequently or reoccurring frequently, anyone that has immunocompromised, comorbidities, diabetes, if they have an indwelling catheter, and are men, thanks to their longer urethras. Okay. So prior to treatment, I always send out a urine for culture. And the reason I do this is I want to make sure that whatever pathogen is causing that infection is susceptible to the antibiotic that I chose. So I want to make sure that whatever is causing that infection, that the antibiotic that I gave them is actually going to take care of it. Now, if the culture comes back and it shows resistance, I can certainly switch that course of antibiotics. Now, anybody ever had to wait on a culture before? Let me know in the chat. Sometimes they can take a couple days, right? Sometimes it takes a little bit. And so we've already started them on these antibiotics, and sometimes it'll show that there's resistance. So in that case, what I do is I call that patient, I say, hey, looks like, it came back positive for this, and this antibiotic isn't going to cover that. So we're going to switch you over. So we just switch that course of antibiotics to one that's going to be effective in eliminating that pathogen that's causing the problem. And it's really great because on that sheet, it's going to tell you like, hey, here's your options. Here's what's going to work. And then you just have to make sure that it's okay and safe for that client. Now, treatment for uncomplicated UTIs is pretty simple. Short round of broad spectrum antibiotics. So like Bactrim, that trimethoprim, sul sulfamethoxazole. Goodness, words today, I tell ya. Or nitrofurantoin, so that macrobid. So we're going to give that for 3 to 5 days. Or even we've seen the use of Monurol in more recent years can be effective, and that can be given as a single dose. Now, complicated UTIs, on the other hand, they're a bit more complicated, really. So broad spectrum antibiotics, we're going to use those, but they differ in both type and duration. So we're going to treat with those penicillins, cephalosporins, fluoroquinolones, or even those beta lactams for 10 to 14 days. So we have a longer course, okay? So longer course for these. So with complicated UTIs, we'll also want to make sure that we follow up and repeat a urine culture following those antibiotics. We want to make sure that whatever pathogen was causing the problem, that it's completely gone. So we don't want them holding on to it and saying, oh, I might use this later. No, we want it completely moved out. Now, what about our patient who has all those typical symptoms of a UTI, but they also have a fever, flank pain, nausea and vomiting? What do we think is going on there? So they have all those typical UTI symptoms, so burning, frequency, urgency, but they also have that fever, nausea, vomiting, and flank pain. What do we think is going on with this client? Let me know in the chat. What do we think is going on with them? Pyelonephritis. Yeah, you got it. Pyelonephritis, what happens is this happens when bacteria continues to work its way up. So remember, we talked about how bacteria doesn't always follow that rule. And so it just continues to work its way up that urinary tract and it ends up finding itself at home in the kidneys. Hey, this looks like a great place to land. So, how do we diagnose pyelonephritis? How do you start? What do you think? That's okay, Anna. No worries. Listen, I've been there. The other day I sent a message to my husband through text and I had to send it like 8 times. No joke. I get it. How are we going to distinguish pyelonephritis? Okay. Might do a urine culture. A urinalysis is a good place to start. And it's going to be very similar to that of someone that presents with a UTI. So we're going to see things like positive bacteria, WBCs, maybe nitrites, lukes, hematuria. But as the infection gets worse, as it intensifies, we're often going to see these systemic symptoms. So, like fever, chills, malaise. They get to the point where they just don't want to eat. Now, on our physical exam, that costovertebral angle tenderness is something that's going to be a key here. Systemic illness plus a urinalysis are enough to diagnose pyelo, but it doesn't hurt to go ahead and get a CBC just to make sure we see what that white blood cell count is. Get a BMP, look for any kidney injury, and sometimes a CT with contrast can be helpful just to kind of help confirm that pyelonephritis or ruling out other conditions. But the other thing to consider here is CT can be really expensive, depending on does somebody have insurance? Is their insurance good? How much do we want? How much can they pay? And so we want to be really careful and cautious when we're doing those things and just being cognizant that, is it something that we actually need or something that would just be helpful? But we actually do want to be very careful with with pyelonephritis, especially when we're seeing that CVA tenderness. We want to be very cautious and make sure that we're following them pretty closely. Now, something else to keep in mind is patients with acute pyelonephritis are usually pretty sick, and sometimes they actually are going to require hospital admission. They might need some IV antibiotics. Now, what would tell me that I need my patient in the hospital? Things like if their fever is continuously high, so it's over that 101 Fahrenheit, pained, marked debility, or they can't maintain oral hydration, or they can't take oral medications, we might just need to send them to the hospital for that IV antibiotics. So something else to consider is that inpatient management is warranted when a urinary tract obstruction is suspected or there are concerns about our client's adherence to what the plan of care is. Now, mainstays of treatment here are things like IV antibiotics like Zosyn, NSAIDs. That's going to help for both pain and fever. The only exceptions here are healthy, non-pregnant women. They can usually be treated outpatient with antibiotics, very similar to UTI treatment. So Bactrim, Cipro, Rocephin, and those NSAIDs. So Rocephin, that one does not feel good, but it usually does the job. Okay, so we've kind of moved along the spectrum of severity here. So we're going to talk about acute kidney injury, or AKI. The name, we recently changed it from acute renal failure, so don't let that name trip you up. But I like to think about it as if the kidneys just all of a sudden they go on strike. Okay. So they become sluggish, they don't do their job, they're not filtering waste properly. And this can happen in many different locations from many different things. So pre-renal causes would be things that actually decrease perfusion to the kidneys. So hypotension, hypovolemia. Okay. And then we have intrarenal or inside the kidneys causes, and those are typically things like medications that cause acute tubular necrosis. So things like NSAIDs, certain antibiotics like Vanc, are really common for that. Now, we've talked about um, intrarenal, we've talked about pre-renal. Now, post-renal is our final one. And things that can cause this, I want you to think anything obstructing flow of the urine. So kidney stones, tumors, they're going to have symptoms like decrease in their urine production, edema of their legs or their eyes. Now, depending on the severity, patients might also have some confusion, shortness of breath, maybe even chest pain. So think about all those things going on and what other things might those mimic? What might we be concerned about? What other things might we be concerned about? You're thinking chest pain, confusion, shortness of breath. So those things, when anytime we see someone that has, okay, CSF maybe. And so anytime we're seeing that heart, that chest pain, difficulty breathing, yeah, Corliss, we're thinking like, oh man, do they have an MI or something? So it's really important that we do a deep dive and figure out what's going on. Now, diagnosis is based on several different lab tests. So things like the BMP, that UA. It's really important that we pay attention to the BUN, the creatinine, and that GFR. Now, these levels are higher than normal or they're trending upwards. If so, we know that something is wrong with the kidneys. Excuse me. We might consider some other testing like a CT, maybe an ultrasound, or even a kidney biopsy if whatever is causing this isn't just really apparent. But in terms of treatment, this is really going to depend. Sometimes it's just as simple as treating the cause. So if they're dehydrated, what would we do for dehydration? Well, we'd probably give them fluids, right? Or maybe there's a medication that's causing it. So we need to stop that medication, watch for improvement. Other times, it's so bad that we might need dialysis until that kidneys can do their job again. So we want to make sure that we follow these patients really closely. All right, so we've talked about our acute kidney injury. So let's talk about chronic kidney conditions. So chronic kidney disease, or CKD, this is a progressive and irreversible condition that's characterized by that gradual loss of kidney function over an extended period of time. Now, the pathology of this is going to involve damage to the nephrons, functional units of the kidneys responsible for filtering blood and removing waste products. And common causes we're going to see are going to be things like hypertension, diabetes. Are you seeing a theme here? Man, hypertension and diabetes, they do a number on the body. Glomerular nephritis, and even autoimmune conditions. So, like rheumatoid arthritis, lupus, things like that. Now, most of our patients are going to remain just completely asymptomatic until those later stages, but there are some that are going to present with things like swollen ankles, shortness of breath, fatigue, hematuria. Those things we should be cautious, we should be paying attention to. Now, as that disease advances, there's going to be this decline in that glomerular filtration rate, that GFR, and that's going to lead to kidney function impairment. Now, something to think about here is different labs categorize CKD based on slightly different eGFRs, but the general idea is the same across the board. CKD is staged based on the GFR, ranging from stage 1, so that would be like mild impairment, to stage 5, which is kidney failure, so really, really bad. And each stage is going to signify a different level of renal dysfunction, and it's going to require tailored management strategies. So when we look at stage one, we see that eGFR of greater than 90. Now, typically, they have normal or slightly increased GFR, and that treatment is going to focus on identifying and managing those underlying risk factors. So, like hypertension, diabetes. Stage two, that's going to involve our mild reduction in GFR with interventions aimed at slowing that progression down. So, blood pressure control, lifestyle modifications, things like that. Now, stage three, we divide this into further categories. So we have stages 3A and 3B, and where we would emphasize managing complications, addressing mineral and bone disorders, implementing dietary adjustments, things like that. Now, stage four marks a significant decline in that GFR, and that prompts more intensive management of those complications, and even preparation for renal replacement therapy. So we're progressively getting more involved here. And stage five, we also call this end stage renal disease or ESRD. And basically, what happens here is we have a need for renal replacement therapy. This can be through dialysis. It can also be through a kidney transplant. Now, what's the best way to slow this down? Well, early detection and intervention. They are crucial for slowing down the progression of this disorder. So, as that condition often stays asymptomatic until those advanced stages, we always want to be looking at our at-risk clients and running labs when we suspect their kidneys might be at risk, and really utilizing our pharmacologic agents to help control their blood glucose and their blood pressure. So, those do a number on the body. All right, so we're going to dive into kidney stones. We also call these renal caliculi or nephrolithiasis. Now, these troublemakers are made up of just solid mineral deposits, usually calcium oxalate, and those form in the kidneys. So, really, anyone could get kidney stones, but we see an increased prevalence in males and those with a family history of kidney stones, dehydration, obesity. Now, my side of the family, almost everybody on my dad's side has kidney stones. So I figured it was just a matter of time, but I'm like, hey, I'm a female, I've got other things working against me. Maybe this one will pass. Apparently not. So, if you or even someone you know has ever experienced kidney stones, you know that pain is excruciating, and it kind of comes and goes sometimes. Sometimes it's just completely just there and it doesn't go away. And it's usually going to occur in that flank area or that lower back. And a lot of times that pain is just so intense that it actually starts radiating to that lower abdomen or even down in the groin. And it can come with hematuria, nausea, vomiting. So we want to make sure that we're doing a good deep dive here. So how do we confirm a kidney stone? Well, we're going to look at a non-contrast CT or even an ultrasound to provide some information on where is it at, how big is it, and then our treatment is going to vary based on how big that stone is. If it's small enough, we can just watch and wait, right? Um, just give some pain management if needed. Tell that patient to drink plenty of fluids, use that strainer so that we know when they pass the stone. But if it's larger, these patients are likely going to need something called shockwave lithotripsy, and that's basically going to break up the stone and allow it to be passed through the urine. So when I had mine, when I went in, it was absolutely terrible. And by the time I got to CT, it was almost into the bladder. So we just kind of did that watch and wait type of situation. They gave me some anti-inflammatories, and I was good to go. Went home, drank so much water. I don't know that I've ever had so much water. So we're going to wrap up this area with one of the more serious GU conditions, and that's bladder cancer. Now, it's a relatively rare form of cancer, but we typically see it more in men, over 55 years old, smokers, those who have been exposed to certain chemicals. But in terms of symptoms, oftentimes they report just painless, gross hematuria as that initial symptom. So remember, we talked about that earlier. They have a lot of urine, so they're looking in the toilet. There's a ton of blood, and they're going gross. So they have that gross hematuria is that initial symptom without anything else. And sometimes that can come with pain or frequent urination or even low back pain. So let's say we have a client, they come in, suspect they have bladder cancer, they have all the symptoms. So what tests are we going to order? What would you think? What type of test would we think about for this patient? They come in, have all those symptoms they just talked about, gross hematuria. One of the first things I'm thinking about is a UA, thinking about a urinalysis with that microscopy. That's a really good place to start because we're specifically looking for hematuria, right? It's also really important to go ahead and just order that urine culture just to make sure that we rule out an infection. And that patient's urinalysis comes back positive for blood in the urine, and the urine culture is negative. So now what? Well, now what we're going to do is we're going to refer them to a urologist for a further workup and for treatment. And typically, that workup is going to be something like a CT cystoscopy to visualize and even biopsy the bladder. And that will confirm both the diagnosis and the stage of cancer if it's there. Now, treatments for this are going to be things surgical, so like a transurethral resection of the tumor or cystectomy, which would remove the bladder completely. And sometimes they might even need radiation and chemotherapy to target any of those remaining cancer cells. Okay, so we've reached the end of our GU section. So, what do you say we take a minute and go through some questions? Anybody want to practice with the information we just went through? Anybody interested? All right. I like it. Okay. So we went through, let's get to our next one here. All right. So 35-year-olds being prescribed antibiotics to treat simple cystitis. Which of the following statements is appropriate for follow-up? Return to the office for blood work if symptoms persist. Return to the office for a UA after 24 hours of being on your antibiotics. Return to the office for a culture in 1 week to ensure resolution, or return to the office if you are not better. What do you think? Which one of these would be correct? All right, let's see how we did here. 3, 2, 1. Oh, 100%. Yes. So if they're not better in 72 hours and it was something simple, we definitely want them coming back. We want to figure out what is it that's going on with them so we know what we need to do next. So typically with cystitis, those should improve after 48 to 72 hours on those antibiotics. Nice work. Great job. All right. Let's look at our next one. So our 72-year-old male client comes complaining of hematuria. He denies any other symptoms. There's no abnormal exam findings. We see a urine dipstick that shows red blood cells, negative leuks, and nitrites. What's the most likely diagnosis here? So positive hematuria. All we see on our urine dipstick is red blood cells. What do you think is going to be our diagnosis? Okay, I'm seeing some correct answers coming in already. Nice job. Nice job. Just a couple more seconds and we will check out the answer. All right, let's look at the answer here. Many of you said, okay, acute cystitis. Our answer here is actually bladder cancer. So remember, he has no other symptoms, just that hematuria. Okay, so when people come in and they have blood in the urine that they're noticing, so gross hematuria and no other symptoms, chances are our most likely diagnosis is going to be that bladder cancer. Nice work. Nice work. Okay, so we've gone through quite a bit of information here. So let's take just kind of a brain pause for a moment and let's talk about what we have to offer here at Archer Review. So when it comes to studying for your boards, we know that it can be a lot. There sometimes you're like, I don't even know where to start. So let me tell you about our SurePass. So this includes our question bank with over 1,600 questions that comes with readiness predictors, which is great because if you're getting 4 to 5 highs or very highs in a row, along with getting through that Q bank, chances are you're probably ready to go ahead and take your boards. We have on-demand videos with over 16 hours of content, just those small broken down videos that are going to go through those difficult concepts in more detail to kind of help break it down for you to understand. We also have a 3-day live review. This is our next one is coming up on May 28th, 29th, and 30th, and it's 3 days from 9 a.m. to 4 p.m. Central Time, where we go through the high yield information that you're going to need to be prepared and ready to go for your NP exam. So go ahead, scan the QR code, kind of see what the hype is all about. Don't take it from me. Make sure you go out and see what students are saying about it as well. But also, we want to develop a community, one that's here to support you in your journey. Whether you're just getting ready to go into NP school, you're getting ready to take your boards, or maybe you are a repeat test taker. We have a community for you. So here at the bottom, let me show you right here. This QR code right here will show you all that we have going on. So we have a Facebook group. We're on Instagram, TikTok as well. So make sure you check those out. All right. So we are going to jump into our final part of today. We're going to switch gears and talk a little bit about those STIs, sexually transmitted infections. We used to call them STDs. And we're going to talk about several different topics. We're going to understand those most common STIs, their symptoms, their treatment, how do we manage it during pregnancy. So let's go ahead and get started with chlamydia. So let's start with a fun fact. Okay, chlamydia is actually caused by chlamydia trachomatis, and it's the world's most common STI. So it's really a big deal. Now, the tricky thing is that so many people with chlamydia don't show symptoms. But if they do, their symptoms look a little bit different for men and women. Now, in women, it might be this yellowish gray vaginal discharge, maybe some itching, burning during urination, maybe some lower abdominal pain, and maybe some irregular bleeding. But for men, it's a lot like a UTI. They'll have burning with urination. They might also have some redness around the urethra, maybe white, watery penile discharge, maybe some testicular tenderness, maybe even some swelling. Now, in our physical exam, we might find some lower abdominal pain in both men and women. But for women, we'll make sure to do a pelvic exam too, because a lot of times what we'll see here is cervical motion tenderness and mucopurulent cervical discharge. And so when we see that, we want to make sure that we swab it for testing. We also don't want to forget to get a urine sample from both men and women because we definitely want to try to rule out that UTI, especially for men because those symptoms can mimic each other. Okay. It really works great for that nucleic acid amplification test or the NAAT. And that's really the gold standard for chlamydia diagnosis. So for men, we're going to use that clean catch urine sample. For women, we're going to run the NAAT with that vaginal swab. And actually, treatment is recently changed in the last few years. While we can still use azithro, used to be our go-to, it's a one and done dose that's safe during pregnancy. But more recent studies are showing us that doxycycline actually works the best. But it's a 7-day course. So our patient compliance is something that we definitely need to think about in that situation. Now, levofloxacin is also an option here, but it's going to require several days of treatment. So again, something to consider with compliance and whatnot. Last but not least, don't forget patient education. Their partners need to be treated because what's going to happen is if they get treated, but they go back to their partner, they're going to get reinfected. Okay. So partners need to be treated too, and they should hold off on intercourse for about a week to prevent reinfection. So we want to make sure that everybody is treated, it's completely gone before they return. Now, gonorrhea, we see this one. It's a close cousin of chlamydia. Typically, we see these come together. Gonorrhea is caused by Neisseria gonorrhoeae, and just like chlamydia, many patients do not have symptoms with gonorrhea. In fact, it's actually the most common STI in those that have HIV. So, always something to be thinking about in terms of that. Now, when gonorrhea does decide to announce itself, one symptom that stands out for both men and women, green or yellow penile or vaginal discharge. Now, when I see that, gonorrhea definitely on my radar. My ears perk up and I'm thinking, oh man. Now, in addition to the discharge, men tend to have symptoms like burning during urination, redness around the urethra, and scrotal tenderness and swelling. Now, women, on the other hand, they tend to have burning with urination and pelvic pain. Now, here's where it comes down to our physical exam. Now, basically, it's deja vu from chlamydia. Okay. We'll do abdominal exams on both men and women, a pelvic exam on our ladies, and we're likely to find some cervical motion tenderness and discharge. So we're going to go ahead, swab that, send it for testing. And we're sticking with our NAAT testing here again, just like we did with chlamydia. So we already know what to do. Clean catch urine specimen for men, vaginal swab for women. Now, it is important to know all sexually transmitted infections are important to treat. But if left untreated, gonorrhea can have some pretty gross complications. I won't go into kind of the nitty gritty here, but definitely we need to know that it can cause some poor damage, some bad damage. Now, as far as treatment, it's really simple. A singular IM injection, Rocephin is all we need, but we can easily treat with doxycycline for a few days too if we need to. It used to be the guideline that we treated all patients with gonorrhea for chlamydia as well, but that's not the recommendation anymore. So unless for whatever reason we're unable to confirm that they're negative for chlamydia, we should always check for both when we run that test. But either way, we are treating for the correct infection. Don't forget partners, again, here, they need treatment too. And we actually want to instruct them to wait to reestablish intercourse to prevent reinfection as well. All right. So syphilis. So this is a tricky STI because like the other STIs we've talked about, it spreads through sex with an infected partner or risky sexual behaviors. Now, what makes syphilis unique is its slow and stealthy progression. It all starts with primary syphilis, a small, firm, painless sore in the genital, oral, or even anal areas about 3 weeks after exposure. We call this a primary canker. Now, if it's left unchecked, it can progress to secondary syphilis. And that's when you might see that red, brown rashes on the palms of the hands or soles of the feet, flu-like symptoms, lingering oral sores, things like that. Now, guess what? Most people don't even consider that these symptoms could possibly be because of an STI. So they typically go untreated. So we move forward a few years, and guess what? Syphilis. It's been in the body all those years, and a person shows up with symptoms that affects their heart, their brain, their eyes. We call these tertiary or even late stage syphilis. Now, with tertiary syphilis, damage that's done to the body is permanent. We can't fix it. We're going to see some diagnostic testing that's going to involve antibody testing, like venereal disease laboratory tests, so VDRL, and the rapid plasma reagent, so RPR. It's important to know that these tests aren't considered positive for syphilis until a primary canker has developed. So if we get these screening tests back and they're positive, we need to reflex them to a confirmatory FTA ABS test before we consider it a true positive. The good news here is that we can cure syphilis at any stage with an injection of bacillin or azithromycin for those that have a penicillin allergy. If our patient has secondary or tertiary syphilis, we may see the treatment repeated. Um, Treatment for partners can be a little tricky, so we want to make sure that we do get them treated and pay particular attention to that. All right, HPV. This is one of those STIs that can manifest in different forms. So, like genital warts, more serious cases, cervical, anal, oropharyngeal cancers. How does it spread? Well, usually it's passed through close contact with somebody that's already infected. And a fun fact is most people have been exposed in their lifetime and their body just kind of naturally clears it of the virus. But another huge risk factor is a weakened immune system. So think low CD4 counts like HIV. These people are at a much higher risk of contracting HPV, but they're not able to fight off the infections. Now, once HPV has found its way into a new host, viral replication is going to occur and it sets the stage for reinfection. Now, first up, there's this latent phase, asymptomatic, no clue what HPV is even there. Okay. So from there, we move into subclinical stage. So still kind of, on the down low, but sometimes we see burning or fissuring in the genital areas. Not always, but sometimes. And when we hit the clinical phase, this is where HPV really makes its presence known. It's like, here I am. It manifests either as genital warts or it changes in cervical cells. And we call that cervical dysplasia. Now, how do we diagnose HPV? Well, this is done through physical exams or just general routine screening. So, if we see a genital wart on an exam, we're going to send a biopsy to confirm HPV. Now, for ladies, screenings are those pap smears, right? Cervical swab to check for precancerous cells that come with the common types of HPV. And there are actually over 100 types, but 16 and 18 and 45 are our biggest threats for cervical cancer. So we definitely are looking for those. Now, the great news is HPV is preventable. We have that HPV vaccine called Gardasil. That's available for preteens. You can even get it as an adult. The only vaccine that we currently have against cancer. So, as for treatment, it's going to depend on what's going on. For genital warts, it might be an excision, maybe cryotherapy, Icomod, which, while precancerous cervical lesions, we're going to diagnose those with like a colposcopy biopsy. We can treat those with a LEEP procedure. But one more thing about HPV is pregnant women and their babies. Now, although that risk is relatively low, pregnant women that have genital warts can actually pass HPV along to their baby during birth, and even can potentially lead to scary complication like warts growing in their mouth, blocking their airway. We call those respiratory papillomatosis. And in some cases, we might even recommend a C-section to be a safer route. There's no risk to moms passing on cervical cancer forms of HPV onto their little ones, but it is definitely something to consider. All right. So after we've talked about all these different STIs, we're going to switch gears and talk a little bit about PID, pelvic inflammatory disease. So what is this? Well, it's a gynecological infection that works its way up through that genital tract, and it affects those reproductive organs in the female. So the uterus, fallopian tubes, the ovaries. It's a big deal because this can lead to infertility and increase the chances of ectopic pregnancy. So young women, typically between 15 and 25, they're the most prone to it. And what do you think the biggest culprit is? It's those untreated STIs, usually gonorrhea or chlamydia. So these patients are going to be pretty uncomfortable. Lower abdominal pain, pelvic pain, dysuria, yucky smelling discharge, irregular bleeding, pain during sex, those types of things. And in order to diagnose this, we're looking for clues on our physical exam. So abdominal or cervical motion tenderness, sometimes we call that chandelier signs, that swinging from side to side, vaginal discharge. So we're going to go ahead and swab that discharge, send that testing out to check for STIs. A pregnancy test rules out ectopic pregnancy, and a urinalysis will rule out a UTI. Now, we're going to run blood tests for other STIs like HIV, syphilis. Don't forget the CBC and the C reactive protein because that's going to help confirm PID. That C reactive protein is telling us about inflammation. Sometimes we can even use an ultrasound, pelvic ultrasound, if we have suspicion that there might be an abscess on the ovaries. But something else to think about is PID patients, they have the potential to get really, really sick. So there's a couple of groups we're going to talk about that we should consider hospitalizing for treatment and IV antibiotics. One of those is pregnant women. If they have failed outpatient treatments, if they're septic as a result of this, and if they have pelvic abscesses, absolutely, let's get them to the hospital, get some inpatient treatment. Our healthy women, they can be treated outpatient with a 2-week oral course of doxycycline. We're going to do 100 milligrams twice a day, and then a one-time IM injection of Rocephin plus Flagyl, 500 milligrams twice a day for 14 days. So they get quite the course, but we definitely want to make sure this is taken care of. Also, making sure that partner gets treated for STIs too. No intercourse until both partners have finished their treatment. And then we definitely want to follow up with them pretty closely. All right, another big one that we see is HSV. So herpes simplex virus, there's two types. HSV1, we call those cold sores or oral herpes, and HSV2, which is genital herpes. But like I tell other students, HSV1 can end up in somebody's HSV2, if you know what I'm saying. So they can have HSV1 in the genital area. Depending on what's been going on. So HSV1 is spread by saliva, um, gives you those fluid-filled pesky blisters or vesicles around the mouth. HSV2 is spread through sexual contact, causes those itchy, painful vesicular sores around the genital area. Other visible lesions, we would be concerned about. We just want to make sure that if they are finding little areas that weren't there before, that we get them treated. Okay. Usually that first HSV infection is pretty rough. They don't feel good. Typically fever, chills, swollen lymph nodes. If it's in the genital area, those inguinal nodes. Typically with subsequent outbreaks, they have those prodromal symptoms like burning, maybe itching or tingling. And that lets them know, hey, I'm about to have an outbreak. And typically they can go ahead and start their medications. Now, this can be tricky to diagnose, especially when we don't have an active outbreak. So we're going to use blood tests like a PCR or a polymerase chain reaction. Um, We can also do a zinc smear and done by swabbing that fluid from the active outbreak to confirm that diagnosis. Okay. So there's no cure for herpes. It just kind of stays in the body, but we can use things like acyclovir or valcyclovir. We can start it within 48 to 72 hours of those symptoms starting to reduce that severity of their outbreak. And then they take a lower dose daily to reduce or prevent those outbreaks. Now, remember, this is contagious even without those visible sores. So make sure we're reminding our patients avoid sharing drinks, lip products, make sure we're using barrier methods like condoms to protect against the spread of this. Okay. Excellent work. All right, let's look at some questions here. Let's see how our understanding is going. All right, nurse practitioners conducting a lecture for high school students on STDs. Which of the following can be prevented by a vaccination? Syphilis, HPV, genital herpes, or trick? What do you think? Which of these can be prevented? Let's see how we did here. All right, 100%. Nice. Whoops. I'm not sure how that one got in here. HPV is correct. You got it. All right. On gynecologic exam, the provider assesses the external genitalia and detects a shallow small, painful ulcer on a red base. Which of the following is most likely? Is it genital herpes, a syphilitic canker, a genital wart, or a cankroid? What do you think? All right, let's see how we did here. Oh, we've got some split here. Many of you said a genital herpes ulcer, and you would be correct. So typically those herpes ulcers, it's shallow, small, painful ulcer with that red base. You got it. All right. So my favorite way to make sure I understand these concepts is to put information into a case study. So we're going to spend the rest of our time together going through this together. So we have a 24-year-old Jasmine Williams comes in. Last menstrual period was 2 weeks ago, regular cycles, no known drug allergies, no big medical history. She was diagnosed a year ago with oh, sorry. She was diagnosed with some issues with her gut and ended up on omeprazole. So she was reporting yellowish vaginal discharge, pelvic pain for the last 4 days. She says she's got some intermittent dyspareunia, burning with urination, and she reports a new sexual partner in the past 2 weeks, not using condoms very consistently. No meds currently. She stopped taking her omeprazole, even though it was prescribed. She's not using any substances, and her vital signs are listed there for us. So 99.4 for her temp, blood pressure 112 over 72, heart rate of 88, and respirations of 16. All right, so she appears alert and oriented. She's mildly anxious, but cooperative. She's maintaining good eye contact, no signs of acute distress. She's dressed appropriately for the weather. No notable abnormalities in gait or posture. Hygiene is good, but she appears slightly fatigued, which she attributes to discomfort and poor sleep because of her pelvic pain. No visible lesions or ulcerations. She has yellow mucopurulent cervical discharge. And we do a bimanual exam, and we've got some cervical motion tenderness, mild uterine tenderness, but no adnexal masses or rebound tenderness. All right, so we go ahead and get some labs, NAAT, HIV, RPR, Hep B, and a wet prep. So what do we think is going on with our client? If you could guess, what do we think is going on with her? Just taking a guess of all the information that we've seen. Okay, so someone's saying PID maybe. Okay, PID. Okay, gonorrhea, chlamydia maybe. All right, well, let's see what our labs came back as. Positive for chlamydia. Gonorrhea is negative. Her RPR, HIV, hepatitis panels, those are negative. And we have no clue cells or yeast on our wet prep. Okay, so that further kind of confirms what we have going on, right? So how would we plan on treating our client? How would we plan on treating her? What would we think we're gonna do? So we know we're positive for chlamydia, but we also have that cervical motion tenderness, huh? A little concerning there. You got it. Yep, absolutely. So we are going to go ahead and diagnose our patient with that uncomplicated chlamydia. We have that early PID going on. We have that cervical motion tenderness. So we're going to give her some doxycycline for 7 days. We also want to make sure her partner gets notified and treated. And then we definitely want them abstaining from sex for 7 days after treatment. We want to make sure they completely finish that treatment. They're both tested or they're both treated before they return to those activities. And then we also want to talk about what could occur if they're, it's not treated, making sure she understands the instructions there. All right. Any other concerns? Do we have any concerns about our partner? Any other concerns there? Sometimes we need to be concerned about, hey, do they have the money for that partner to get treated? So there are some times when providers will just go ahead and write a prescription for the partner. Make sure they get treated, make sure they understand how long they should be abstaining is another one. Yes, they absolutely need treatment. Now, if she was interested in birth control, what might you recommend in that situation? If our client was interested in birth control, what might you recommend? Maybe not right now, but when she is able to return, what might we recommend in that situation? Maybe an IUD. I like it. Condoms would be a good one. Okay, so we need to do some more. We want to know, does she have any risk factors that would not make her a candidate for those combined oral contraceptives? You got it. So we want to make sure that we're not judging when we're counseling her, that we are talking about, hey, coming in and getting screening with changing of partners every year if you're concerned, talking about those long-acting reversible contraceptive methods, but also talking about the risk there. So we have a string that if she has an IUD leads right up to the uterus. So we want to make sure we're catching those STDs pretty quickly. And then talking about dual protection. So making sure that she has something for birth control, but she's also protecting herself against those STDs. All right. So what would you guys say is the best way to reduce her risk for recurrent STIs? This is our last question before we're done. You guys have been amazing. Thank you so much for joining. What's the best strategy to reduce her risks? Condom use. I like it. Education, counseling. Yes, you got it. And making sure she has access to those things is very important. Safe sex practices. You got it. A lot of college campuses, a lot of providers even have condoms readily available for our patients to take. Well, thank you guys so much for joining me. This has been so much fun. I hope you have learned a little bit more, but one more question before you go. How do you feel about the GU system and the subject of STDs now? So we've gone over quite a bit of information. How do you feel about these areas? All right, we got some fives already. Nice. 10 out of 10. Got some fours. This is looking a whole lot better than it did to begin with when we had some ones. No worries if you are still at a one, but I'm so glad. I'm hoping that you learned quite a bit from our time today. I've enjoyed being with you. I think the time that it took you to respond gradually got faster as we went on, and you're responding with more confidence. I'm absolutely completely wowed by your knowledge. So remember, if you're still struggling with knowing what to do, how to prepare for those board exams, check out our SurePass. We have some amazing opportunities for you. That 3-day live is coming up at the end of next month. I hope you will join me. And it's been a pleasure working with you this afternoon. Please, if you have questions, don't hesitate. Send us an email to nursepractitioner@archerreview.com. These go directly to us and we respond individually. Thank you so much for joining us, and we hope to see you at our next webinar. Take care.